العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we will continue the subject of vascular imaging, and we have started by the lymphatic system, and the previous lecture was about the imaging of the lymphatic vessels. Now we will proceed by the imaging of the lymph nodes. And here we want to talk about the anatomy and some of the imaging techniques, and also we would like to have an idea about the lymph node pathology. Then the imaging modalities used for evaluation of the lymph nodes will include the plain X-ray, the contrast radiography, including the previously mentioned lymphography, ultrasound and Doppler, CT, MRI, then the PET and PET-CT, and finally, which is one of the good diagnostic tools, which is the fine needle aspiration cytology or even the core biopsy. And, lymph node pathology is quite variable, and it includes a broad spectrum of diseases, and we will have an idea about the appearance of reactive lymph nodes and the inflammatory nodes, including the bacterial and TB lymphadenitis. Then some words about sarcoid, cat scratch disease, infectious mononucleosis, HIV lymphadenitis, Kawasaki disease, Castleman disease, Kimura disease, then the malignant nodes, including the metastatic and the nodes of lymphoma. And you know that the structure of the lymph node is quite complex, but what do we mean here is the appearance of the lymph node, which is in the form of a kidney shape or reniform appearance with multiple afferent lymphatic vessels entering the node through the convex border or the capsule, while the efferent lymphatic will go outside through the hilum, and in this particular area the feeding vessel and the draining vein also are present in the hilum of the lymph node. Lymph node functions are quite let's say variable, and we have the phagocytic filtration of particulate, antigenic, and other noxious matter. Also, lymph nodes have a role in the cellular and the humoral immune responses, and also in the generation of lymphocytes and other antibody producing cells. Then you remember we talked about lymphography, and we said that we inject the contrast material, which is lipiodol, in the lymphatic vessel on the dorsum of the foot after exposing this vessel by a small incision. And during the or after we finish injection of contrast, we take films for the appearance of the lymphatic vessels. And next day we will have other films for the lymph nodes, what we call the nodal phase. And this nodal phase will show the lymph nodes in the pelvis and also the lymph nodes in the abdomen. And you remember that nodes seen by lymphography will include the inguinal, external iliac, and common iliac and para-aortic lymph nodes. The internal iliac nodes are not shown by lymphography. And the nodes vary in size from microscopic size up to 2 centimeters, and the number of lymph nodes all over the body may reach 600. And we have a frontal radiograph for the abdomen and oblique views in order to have the lymph nodes away from the spine so that we can evaluate the nodal size and the pattern of contrast filling. And we consider the average size of the lymph node is within 2 centimeters in diameter, but we in lymphography we accept large nodes as normal or hyperplastic if they maintain their normal shape, which is the shape of the kidney, and they are homogeneously filled with contrast material. Whenever we see a node like this, and this node is having the reniform shape and it is homogeneously filled with contrast, we consider it as normal. You can take this node as an example, but here you can see some incomplete filling of the lymph node. Then some of the nodes that are draining frequent sites of infection, like the inguinal nodes and most of the submandibular and submental lymph nodes, they drain frequently inflammatory lesions in the head and neck. Then we consider these nodes uh, are not considered pathologic, even if they are a little bit larger and show some filling defects. These nodes are what we call the reactive lymph nodes. I will mention after that. And the lymph nodes in the neck are located in these particular areas in the submental area around the submandibular salivary gland in the upper and lower deep cervical regions deep to the sternomastoid muscle and the posterior triangle of the neck. These are known as spinal accessory lymph nodes and also in the supraclavicular area. And this is the distribution of cervical lymph nodes according to the groups. When you have group 1A are the submental group, group 1B are the submandibular group, group 2, 3, and 4 are the deep cervical lymph nodes. They are divided by the hyoid bone and the level of the cricoid cartilage. Then we have the posterior group of lymph nodes. These are finally the supraclavicular lymph nodes. And it is usually considered on imaging that lymph nodes within the range of 1.5 centimeter, they are considered hyperplastic lymph nodes, but lymph nodes in other regions of the neck are considered pathologic if they reach the 1 centimeter size. And there is some equations to differentiate between the metastatic nodes and the hyperplastic nodes. We consider the nodes hyperplastic whenever they are of homogeneous density or homogeneous ecotexture, and they maintain the normal reniform shape. And here, if you divide the maximal longitudinal diameter by the maximal axial diameter, if it is less than 2, then this means that the nodes are no more reniform, they are towards the rounded shape, and you think of metastasis. But if this division results in a figure more than 2, then you consider the possibility of hyperplastic nodes. And if you look here, and we have many nodes in the cervical region, these are the submental group, which are usually located between the anterior belly of digastric muscle. The submandibular group are seen around the submandibular salivary gland. This is the submandibular salivary gland. These are the nodes, the gland, and these are the lymph nodes. Then the deep cervical lymph nodes are seen behind the sternomastoid muscle or deep to the sternomastoid muscle. These are the group of deep cervical lymph nodes. Lymph nodes in the chest we have discussed many times before, and they are seen in 9 anatomic sites. The retrosternal group, which are located behind the sternum, also known as internal mammary group of lymph nodes. The retrocaval are located behind the superior vena cava. Also, they are known as right paratracheal lymph nodes. The prevascular nodes are located along the anterior aspect of the aortic arch, and the aortic window group of lymph nodes are located between the ascending and descending aorta before the appearance of the pulmonary artery. And we have the carinal lymph nodes. The precarinal group are anterior to the carina. The retrocarinal group are posterior to the carina. The subcarinal nodes are located between the main stem bronchi. We have the hilar group of lymph nodes, also known as the bronchopulmonary lymph nodes. Then we have the zygoesophageal or posterior mediastinal nodes, which are related to the azygos vein and the esophagus. And finally, we have the circumcardiac lymph nodes, which are arranged around the pericardium. And if you remember, these nodes are pathognomonic for non-Hodgkin lymphoma in both the pediatric and adult age groups. And the plain X-ray can show some of the nodes, especially in the chest. And we used to look at these enlarged hilar shadows as either representing enlarged lymph nodes or they may represent prominent vessels. And in order to differentiate, we have to have the lateral X-ray, and if these are nodes, there will be an extra density superimposed on the hilum, diagnostic of lymphadenopathy. But if you don't see any extra density superimposed on the hilum and you consider this appearance belongs to vessels. This is the appearance of lymph nodes by CT and MRI. Nodes are soft tissue masses located at the anatomic site known for lymph node. They may be homogeneous, they may contain some areas of breakdown and may contain calcium according to the disease. And by MRI, lymph nodes will appear of intermediate signal in the T1 and some signal increase in the T2 weighted image, as you can see in this area. And lymph nodes in the abdomen are located behind the diaphragmatic crura, and this is known as the retrocrural nodes. Also seen in the porta hepatis, the para-aortic, the aortocaval between the aorta and the IVC. This is a group of lymph nodes. Mesenteric lymph nodes are arranged around the root of the mesentery, and iliac lymph nodes are seen around the common iliac arteries and also in the region of the internal and the external iliac arteries. And finally, you see the inguinal group of lymph nodes. The lymph nodes that are considered normal should be in the range of 1 centimeter in the long axis of the lymph node in the axial image. When we consider the upper limit of the reactive node is about 1.5 centimeter, and you know that reactive nodes are located at areas draining frequent sites of infection, usually in the inguinal region and in the cervical region as well. In the ultrasound, appearance of normal nodes include number 1, well-defined kidney shape. Number 2, the presence of fatty echogenic hilum. As you see, the hilum of the node contain fat, and fat in ultrasound is echogenic. Then hypoechoic cortex relative to the adjacent muscles. This is the cortex, which is hypoechoic. And if you use the color Doppler facility, you may not see any vascularity, or you see some vessels entering the hilum of the node like this. And this is an oval shaped node containing a central echogenicity representing the hilar fat, and on Doppler examination, and you see some vessels entering the hilum of the lymph node. And this is a good example of reactive lymph nodes in the neck. And if you look carefully here, and you see some nodes in the region of the submandibular gland, and some other small nodes deep to the sternomastoid muscle. And I want to say that these nodes should not be considered pathologic. They are usually referred to as reactive lymph nodes, since they are in the range of 1.5 centimeter and they are homogeneously enhanced. And it is considered one of the mistakes is that you consider these nodes belong to metastatic disease, for example, in patient having primary malignancy even in the neck. Then we should be careful about nodes in the neck before saying that these are metastatic or not. And you consider the size, and you consider the enhancement, and if there is an overlap, then we should go by the usual and the regular way for confirming the diagnosis is to obtain a biopsy by ultrasound. And lymphadenitis or inflammatory lymph nodes are usually the result of staphylococcal or streptococcal infection. They represent about 70% of unilateral cervical lymph node enlargement. When the lymph node is inflamed, then you expect that it will appear anechoic on the ultrasound. It will have some increased vascularity, especially along the periphery, and you expect a loss of the central fatty echogenic area. Instead, you may see some fluid inside the lymph node. Then you got the appearance of cystic changes and maybe posterior acoustic enhancement similar to cysts elsewhere in the body. Then inflammatory nodes will affect the surrounding fat and the surrounding tissues. Then you got stranding of the fat, and this feature is not seen in the metastatic nodes. And by ultrasound, suppurative inflammation of the lymph node will result in a slight enlargement of the node, anechoic or hypoechoic appearance, loss of the central echogenic fatty hilum, and increased vascularity in the vicinity of lymph node. And this is an acute lymphadenitis in a patient with history of intravenous drug abuse presenting by palpable painful swellings. And they see the marked increased vascularity of the inflamed nodes. By CT and the MRI, you can see that the inflamed node will contain central area of breakdown, and it will show marginal enhancement exactly similar to an abscess. And the nodes that are frequently seen like this are those of tuberculous lymphadenitis. And inflammatory lymphadenopathy on the left side in the region of the submandibular gland, you see the lymph node is considerably enlarged. It contains its central area of breakdown. And what's very important here is to look to the subcutaneous fat, which shows the stranding appearance characteristic of inflammation. And this, as I have mentioned, not seen in metastatic nodes. In the spread of infection in the perinodal area, may result in the formation of an intranodal and perinodal abscesses like in this area. And you see this is the sternomastoid muscle, and this is the lymph node with the development of an abscess inside the node as well as adjacent to it. And this patient with tuberculous lymphadenopathy, and you see some of the nodes are homogeneously enhancing, indicating that this is acute phase, and the other nodes are centrally necrotic, simulating an abscess, and this is the subacute phase of tuberculous lymphadenitis. And then TB lymphadenitis, especially in the neck, represents about 14% of extrapulmonary tuberculosis. In the acute phase, the nodes will show homogeneous enhancement. In the subacute phase, the nodes will show central breakdown. In the chronic phase, the nodes will show calcification, and this calcium is also seen after treatment and healing. And in cases of tuberculous lymphadenopathy, there is no perinodal inflammation, and this will make some difficulties in differentiating TB from metastatic nodes, which do not show perinodal inflammation. And you know that the final destination in all lymph node diseases is to have a cytology or core biopsy, usually guided by ultrasound to confirm the diagnosis. This is the appearance of tuberculous lymphadenopathy by ultrasound. The nodes are hypoechoic, they are enlarged, they may be amalgamated or matted together, and you do not see some vascularity inside the nodes, but you see displacement of the vessels around the nodal masses. And this is TB lymphadenopathy by ultrasound and by Doppler. Then this is the follow-up ultrasound scan showing the regression in the size and the healing of the inflamed nodes. This appearance is usually characteristic for TB lymphadenopathy, especially in the cervical and in the thoracic area and also in the abdomen. You see that the nodes are marginally enhanced and they contain necrotic center, and each of the node is usually simulating a small abscess. Most of the nodes are usually amalgamated together, as you can see here. This is also another example of tuberculous lymphadenopathy, upper deep cervical lymph nodes on the left side, and also multiple lymph nodes on the right side deep to the sternomastoid muscle. And you remember that tuberculous lymph nodes in the chest, whenever they are associated with pulmonary lesion, especially in the pediatric age group, and you call this the TB primary complex. And you have a solitary lesion in the lung, and this lesion is usually located subpleural, and you got mediastinal lymph nodes with necrotic center. And this is the arch of the aorta, this is the superior vena cava, and here you see the necrotic node. This, of course, is the thymus, and in the presence of a pulmonary lesion, you call this TB primary complex. And sometimes you can see that the nodes contain calcium, especially after treatment or after healing. And you see the pulmonary lesion, and you see calcium in the prevascular nodes as well as in the retrocaval nodes. Sarcoid is a non-caseating granuloma affecting many systems in the body. The etiology is unknown. And the usual age of sarcoid is between 20 and 40 years. 50% of the patients are usually asymptomatic, and 50% may develop respiratory or skin symptoms, but orbital involvement and salivary gland involvement are frequently seen in the clinical practice. Then 5% of the patient may have involvement of the central nervous system, and in most of the cases there should be an intrathoracic disease which may be symptomatic or asymptomatic. The nodes of sarcoid are characterized by their discrete appearance. They are homogeneously enhanced and they may contain calcium. And in this CT scan of the neck, and you see some homogeneously enhanced nodes that are not amalgamated. They do not contain central areas of breakdown. And this is a good appearance of sarcoid in the chest, bilateral symmetrical enlargement of the hilar shadows, and in the neck you see nodes that are discrete and they are homogeneous, intermediate signal in the T1, high signal in the STIR images, and this appearance is usually suggestive of sarcoid lymphadenopathy. In cat scratch disease is a regional lymphadenitis secondary to infection by Bartonella henselae infection, and this usually affects the children and young adults. The lymph nodes will appear in the range of 3 weeks after the cat scratch. Then the most common site for cat scratch lymphadenopathy is the epitrochlear nodes located near the elbow, followed by the axillary nodes, and followed by the cervical nodes. And this is also may be seen in the veterinary people, where you can see, and this is the appearance, which is uh, undistinguishable from other inflammatory nodes, but the location and the history are will direct to the accurate diagnosis, and they see the node is swelling with extensive hypervascularity. And this is an example of epitrochlear lymphadenopathy due to cat scratch disease. There is a big lymph node near the elbow and of intermediate signal in the T1 and increased signal in the T2 with homogeneous post-contrast enhancement. And by Doppler ultrasound, you can see some vascularity within the node. Infectious mononucleosis is secondary to Epstein-Barr virus. There is diffuse involvement of the lymph nodes, and the affection of the adenoids and the tonsils is one of the helpful diagnostic criteria for infectious mononucleosis. In this type of inflammatory nodal disease, you do not see perinodal inflammatory changes. And this is an example of infectious mononucleosis with some enlargement of the lymph nodes around the submandibular area and upper deep cervical region. And the nodes are classically homogeneously enhanced with no areas of breakdown. And the differential diagnosis of infectious mononucleosis may include sarcoid, viral infection, histiocytosis, and Castleman disease, which also a disease resulting in enlargement of the nodes with homogeneous CT density and also homogeneous enhancement. Then lymph nodes are usually present in almost all patients having HIV infection, and is considered one of the common initial presentations. And lymphadenopathy is present in about 40 to 70% of HIV positive children. And the nodes are usually having the appearance of the reactive inflammatory nodes. The nodes are not significantly enlarged, and they are homogeneously enhanced. And some of the helpful diagnostic criteria are the presence of parotid cysts, which are the HIV-related lymphoepithelial cysts commonly seen in the parotid glands in patients with HIV infection. And the lymph nodes of HIV are homogeneously enlarged, homogeneously enhanced, and they are slightly enlarged. And the presence of multiple cystic lesions within the symmetrically enlarged parotid glands is usually helpful in the diagnosis of these lymph nodes to belong to HIV. And these cystic changes are referred to as HIV-related benign lymphoepithelial lesions, and they are also seen in patients with Sjogren disease, where you got symmetrical enlargement of the parotid glands with multiple internal cystic changes, and you know the intimate relation between Sjogren and non-Hodgkin lymphoma. In Kawasaki disease is the febrile mucocutaneous lymph node syndrome, and is usually recognized in infants and young children. This is the common age of presentation between 6 months and 2 years of age. And this, most of the patients will present by fever for 5 days with no evidence of an inflammatory disease. Then lymphadenopathy will be sometimes mistaken for bacterial lymphadenitis, but in Kawasaki disease, the nodes are coalescent, forming a mass or cluster of grapes. Then you see here some of these nodes in deep to the sternomastoid muscle. The nodes are homogeneously enhanced and they do not show perinodal inflammatory changes. One of the good manifestations of Kawasaki disease is the presence of aneurysms of the coronary arteries. And this patient, 18 years old, with Kawasaki disease, having an aneurysm in the coronary artery. And Castleman disease is a disease of unknown etiology. It presents by lymphoproliferative hyperplasia of the lymph nodes. The affected nodes are enlarged, they are homogeneously enhanced, and sometimes you got calcium, especially in the nodes in the pelvis affected by this Castleman disease. And Castleman disease will result in enlargement of the lymph nodes, and the nodes are usually of homogeneous texture on ultrasound and also on CT. And whenever you inject contrast medium, there is homogeneous enhancement, and many times the enhancement is strong. On MRI, they show hypointense appearance on T1 and hyperintense appearance on T2, and if you inject contrast material, they will show homogeneous enhancement. And this is stated in the literature that the presence of a central non-enhancing scar within an enhancing lymph node mass on CT may suggest the possibility of Castleman disease. But you have seen that a lot of lymph nodes will show enlargement and homogeneous texture like the sarcoid and the Castleman disease, infectious mononucleosis, Kawasaki disease, and as I have mentioned that if the clinical picture is not helpful, then the only way to confirm the diagnosis is to go by ultrasound and have a fine needle aspiration cytology or even a core biopsy to confirm the diagnosis. And this is the case of Castleman disease, showing multiple variable sized, homogeneously enhanced lymph nodes around the submandibular salivary gland and also deep to the sternomastoid muscle. Kimura disease is an inflammatory disorder, and this lesion will affect the subcutaneous tissues, the lymph nodes, and the salivary glands, especially the parotid. And commonly seen in boys and men during the second and third decades of life. The nodes are usually non-tender, and they are not usually surrounded by inflammatory reaction. On imaging, you got enlargement of the lymph nodes that are homogeneously enhanced and hypervascular, and you got unilateral or even bilateral involvement of the salivary glands, especially the parotid gland. Then this is an appearance of a Kimura disease in a male 14 years old. You got enlargement of the lymph nodes on the right side associated with ipsilateral enlargement and signal changes in the parotid gland. And this is the case of Kimura disease with enlargement of the lymph nodes deep to the sternomastoid muscle, and you got a lesion which is of high signal in the T2 weighted image in the left parotid gland. And we came to the malignant lymphadenopathies, and we include the metastatic disease and lymphomas. These are the clinical suspicions criteria for malignant lymphadenopathy. The nodes are hard, non-mobile because of the invasion of the surroundings. Sometimes they are, or frequently they are painless. The nodes on follow-up, they show progressive increase in the size. They do not respond to antibiotic therapy, and there are no associated systemic manifestations like fever and so on. Then on ultrasound, the nodes are the malignant nodes appear enlarged. They are no more like having the reniform configuration. They are more or less rounded. There is absence of the central fatty echogenic hilum. The parenchyma is hypoechoic. The nodes may have the tendency to aggregate together, forming nodal mass. On ultrasound, there is subcapsular hypervascularity, as you can see here, displacement of the hilar vessels, and absent segments of the blood vessels due to invasion by the malignant disease. On CT, the best diagnostic criteria for metastatic nodes is the presence of the central areas of necrosis. And at that time, you may be confused by the nodes that show central areas of necrosis, and these are the inflammatory nodes due to bacterial and TB lymphadenopathy. But you remember that bacterial lymphadenopathy will have some perinodal inflammatory changes, while TB lymphadenopathy will not. So that if the clinical picture and the imaging findings are not characteristic to separate the malignant from tuberculous lymph nodes, then you go by needle biopsy to have to confirm the diagnosis. Extracapsular spread of the tumor within the lymph nodes has a poor prognosis and is diagnosed in imaging by ill definition of the nodal margin and enhancement extending outside the confinements of the lymph node into the perinodal soft tissues. And these features are suggestive of extranodal extension, which is not seen in the inflammatory nodes. Then the presence of a non-primary malignancy is one of the helpful clinical criteria for the diagnosis of metastatic lymph nodes, and this is a necrotic lymph node on the left side of the neck in a patient with nasopharyngeal carcinoma, and this is metastatic lymph node. And this patient have an oral cancer, and you see a mass at the base of the tongue encroaching on the oropharynx, with a lymph node here and a big one here posterior to the submandibular salivary gland, diagnostic of metastatic lymphadenopathy. And this patient with esophageal cancer and bulky necrotic lymph nodes in the right parapharyngeal area. And of course, you know that these nodes are not usually seen in lymphoma, especially the nodes that are containing central areas of breakdown. Number two, the presence of primary malignancy will enable you to predict that these nodes will be metastatic. And lymph nodes by ultrasound that are metastatic, the nodes are more or less rounded. They show areas of central necrosis and they show prominent vascularity on the Doppler study. And on the previous days, we used to diagnose metastatic nodes and nodes of lymphoma by lymphography. And if you see this patient with cervical carcinoma, you got multiple filling defects within the nodes, which are of abnormal appearance, as you can see here. And these nodes are diagnostic of being involved by metastatic disease. Then central necrosis is the most reliable feature of metastatic nodes. And this central necrosis, in my opinion, is somewhat different from the central necrosis seen in inflammatory nodes, but this is not pathognomonic. If you look to the inflammatory node, then you got regular inner margin, exactly similar to an abscess anywhere in the body. But the central necrosis in metastatic nodes usually has an irregular inner margin because the necrosis here is not going in a similar way to the necrosis of the inflammatory nodes. And also, you remember that inflammatory nodes may, especially those of bacterial etiology, will have some perinodal inflammatory changes where here you do not see. Also, you consider the presence of primary malignancy or you see it or you know from the history, this is a tumor of the lower lip with metastatic nodes on both sides of the neck. And this is an example of an inflammatory node. Or this is a case of oral cancer. You see this ill-defined enhancing mass in the anterior aspect of the mouth floor. And also you can easily appreciate the presence of metastatic node deep to the sternomastoid muscle. And this is one of the techniques used for evaluation of lymph nodes using this paramagnetic contrast material known as ultra small super paramagnetic iron oxide, or USPU, or SPU without ultra small. And these are nanoparticles injected intravenously. They are composed of iron oxide core and covered by dextran, and these particles can go through the lymphatic vessels and deposited into the lymph nodes, and they are usually taken by the macrophages in benign nodes. Then you expect the deposition of iron in the lymph nodes will have a very dark signal on T2 weighted images. And this is the appearances in the T2 weighted image and the appearance after injection of this contrast material. And this is the appearance of nodes with of benign nature. Either the node is totally black due to homogeneous deposition of iron oxide inside the node, or you got some black areas within the node itself. These are the appearances of benign nodes. These are the appearances of malignant nodes. The presence of malignant cells prevent the iron from being deposited in the node. Then in the T2 weighted image, the node will appear bright, and after injection of iron, it may totally appear bright, or they may contain a good area of brightness, which represent the area where the malignant cells are present, and this is the area where the contrast is deposited, the iron oxide. Then if you look carefully here, and this is T1 and this is T2 and this is T2 after injection of the SPU. Then look at these nodes, which are located here. They are of intermediate signal in the T1 and they are bright on the T2 weighted image. After injection of iron oxide, and you see the nodes are black, meaning that they are benign. But look at this lymph node, which is of dark signal in the T1, bright signal in the T2, and still of bright signal after injection of iron oxide, meaning that it is a malignant node. And this is also an example of a lymph node in the axilla. And this is T2 weighted image, and after injection of a SPEW, the node will show persistent hyperintensity, denoting that it is malignant. And this is also an example. You see the node in T2 weighted image of bright signal. After injection of SPEW, part of the node is black and part of the node show hyperintensity, and this is malignant node. And you remember that I used to say that lymphoma nodes are usually bulky, they are amalgamated, they show homogeneous enhancement, and they do not contain calcium. Actually, you know that you cannot diagnose by imaging or differentiate between Hodgkin and non-Hodgkin lymphoma, but you remember the best way for diagnosis of lymph nodes for sure is to have the fine needle aspiration biopsy guided by ultrasound, especially. And here you know that non-Hodgkin lymphoma is much more common in the clinical practice than the Hodgkin disease. And this is an example of Hodgkin lymphoma in a male 75 years old with the characteristic appearance of lymphoma nodes. The nodes are bulky, they are homogeneously enhanced, they are somewhat amalgamated together at the root of the mesentery and the para-aortic area. Some of the lymphoma nodes, especially those with nodular sclerosing Hodgkin disease, may show central areas of necrosis, and this may be mistaken for inflammatory nodes, for example, or metastatic lymphadenopathy. You know, the best way is to go by biopsy to confirm the diagnosis. Lymphoma nodes by the previous technique, the lymphography, are usually have the appearance of soap bubble. The nodes are considerably enlarged and they are faintly stained by the injected contrast material. This appearance of nodes on lymphography is somewhat suggestive of lymphoma. Then lymphoma by ultrasound, the nodes are bulky as in any imaging modality. The presence of calcium in the lymphoma nodes is debated. Some literature say that calcium is present in the nodes, especially after treatment, and others say no, you can see calcium before treatment and you can see calcium after treatment. Let's say that the lymphoma nodes are bulky, they are of homogeneous echo texture like this, and they contain some vascularity. And this is lymphoma nodes before treatment and after treatment. The node is bulky, is almost homogeneously hypoechoic with some vascularity, and this is the follow-up with regression of the nodal size. This is Hodgkin disease nodular sclerosing type with necrotic nodes that are bulky, mainly located on the right side of the neck. And lymph node calcification can be seen in neoplastic and non-neoplastic conditions. In cases of non-neoplastic conditions, TB and sarcoid are on the top of the list. Other granulomas, scleroderma, Castleman disease, amyloid, and pneumoconiosis. On the neoplastic side, you have lymphoma and metastasis after treatment, and deposits of coming from the lung or the breast or the colon, especially the mucinous type, some nodes from the prostate, ovary, osteosarcoma, and thyroid carcinoma may contain calcium. And one of the diagnostic tools used for evaluation of lymph nodes is the PET scan. And you know that PET CT is the combination between the PET machine and the CT to enhance the anatomic details of the part to be examined. And the reasonable isotope used for PET examination is the fluorine 18 because of its reasonable half-life, which is in the range of 110 minutes. Then this isotope is injected intravenously, and then the patient is scanned, and you look for the metabolic activity of the region to be examined. This isotope is selectively uptaken by the areas of high metabolic activity, and the uptake can be evaluated by vision and can also evaluated by the machine in the form of this unit, which is the standardized uptake value, or SUV. The SUV is considered by some of the literature if it is more than 2.5, and you consider malignancy, but other literature say that the sensitivity and the specificity are in the range of 81 and 94% respectively, for if you consider the standard uptake value more than 3.64, especially the small pulmonary nodules. Then considering the lymph nodes, you look for the standard uptake value by vision or by measuring the uptake value, and you can have, of course, some false negative results and false positive results, and it is well known in the literature that the PET-CT is almost useless in evaluation of lymph node disease in countries where TB and sarcoid are prevalent. And this is an example, and see there are lymph nodes in the mediastinum, and the nodes are homogeneous. They do not contain areas of breakdown. And on the PET-CT, and you see considerable or marked uptake by the lymph nodes. And if you consider the standard uptake value, you may think that these nodes are malignant, but actually they proved by biopsy, which is the mainstay for evaluation of lymph nodes, and they proved to be tuberculous etiology. And these nodes are also homogeneous. They are located in the mediastinum with very hot uptake of the isotope, and these nodes are proved to be due to sarcoid. These nodes are due to lymphoma. You see a homogeneously enhanced nodal mass, and you see also another mass in the chest wall. Both showed marked increased uptake of the isotope, and this was proved to be secondary to lymphoma. Then you remember this algorithm when you can approach the diagnosis for lymphadenopathy anywhere in the body, considering the clinical and the imaging appearances. Then if you have in the clinical picture a non-primary malignancy, then you may consider nodal deposits. If you know that this patient has lymphoma, then you consider lymphoma. If the patient is known to have sarcoid, then consider sarcoid. If there are signs of inflammation, then you consider inflammatory nodes. On imaging, if you see the primary malignancy like nasopharyngeal cancer or oral floor cancer, then consider metastasis. If you see the nodes are bulky, homogeneously enhanced, then you consider lymphoma. If you see nodal calcification, you consider inflammation, and you should remember that there are some of the nodes that are malignant may contain calcium. If they see necrotic center, you consider inflammatory nodes, and also remember that the metastatic nodes consider necrotic center, and you are able now to differentiate between both. And if there is an overlapping picture, you need to go for biopsy. And this is the way I used to report the nodes is anywhere in the body. If you do not have a suggestive clinical data or suggestive imaging finding, you just say in the report. These are lymph node pathology. This is lymph node pathology, and the best way for evaluation is to go by a biopsy to confirm the diagnosis. Thank you very much. Alhamdulillah.